Competition finals round. My name is Breon Simmons, and I will serve as your moderator. Just a few reminders. Please make sure that you silence your cell phones and all communication devices. Before we begin, we're going to allow the team to introduce themselves, as well as introduce our judges.
Thank you. We are Team O. I'm Scott Williams. My team members are Mary Pettis and Katriana Lewis.
Thank you.
Good afternoon. I'm Jennifer Campbell Fitzgerald.
Hello, I'm Denise Brooks Williams.
Hi, I'm Pam Sutton Wallace with Duke University Hospital.
Thought I was going to say pastor.
That's what I get.
I apologize. So I get to mess with the Lord. I'm Dale Oliver with HCA. Thank you.
And I am Pastor Herb Buchanan.
Yvonne Spence, Dignity Health.
And Ken Page, Catholic Health Partners.
Thank you. You will have 20 minutes to present your case. The timekeeper will notify you when you have 5 minutes remaining, as well as 2 minutes remaining. Once you finish your 20-minute presentation, we will move straight into the Q&A session, which there will be 10 minutes allotted for that. As a reminder for our audience, please note that once the team begins, there will be no entry or exit out of the room. Thank you.
Thank you. Y'all ready? Okay. We're ready to begin. On behalf of Catholic Health Partners, my team members and I have developed a care coordination model that intends to meet the patient needs, eliminate the fragmentation of care, reduce the overall utilization and cost of care, while improving our patients' overall health outcomes. A little overview of our care model. We intend to partner with social programs, FQHCs, Catholic Health Partners, and Aetna and Buckeye Health Plans. We intend to serve the dual eligible population for Northwest Ohio, and as I had said before, reduce the overall utilization of costs of care while improving our patients' overall health outcomes. Our population that we intend to serve is adults and seniors with disabilities, with severe mental illnesses, substance abuse issues, as well as chronic illnesses or diseases. We have broken our patient population into 3 different distinct risk groups: low risk, moderate risk, and high risk. We have developed a criteria for stratification for these different risk groups. First, for low risk individuals, they're going to be adults and seniors that are healthy individuals and adhere to regular healthy checkups. Our moderate risk individuals are going to be seniors that have 2 or less of the following diagnoses, such as hypertension, diabetes, obesity, and among others. Our high-risk individuals are going to be individuals that have 2 or more of the diagnoses, have visited the ED twice in the last 180 days, and have also been identified by physicians as high-risk individuals with the inability to adhere to a care plan. We have identified this population as high care and high need individuals that are going to be seamlessly integrated into our care model.
So the first step in integrating these patients into our care model is through the use of our patient cloud. And what this shows is that the various ways patients will come into our model. They may come in through hospital ER visits, through state agencies such as nursing homes and long-term care facilities, or through the local FQHCs that are out in the community. Next, we would involve our care team, who would start to collect information on patients through various ways such as EMR records, intake notes, or individual care plans that may have been established for some of our patients. From there, the care coordination team will begin to meet monthly. They would work with a small outreach team in order to locate and identify patients that we feel would be able to be enrolled in our program. From there, patients become enrolled in the program, and then our case management review team will look over the information that they've been gathering on patients and evaluate the health status of both new and existing enrollees. They would also make suggestions to our providers on possibly moving patients from one of our subgroups that we've previously identified to another. as seen in the bottom of the graph. This shows our staffing model that we've developed. We came to the conclusion that we would need approximately 19 FTEs within the first year. This would increase to 36 FTEs in the second year, and then increase again to 70 FTEs for the third year. We've based these numbers on two aspects, which include the predicted enrollees for each year, as well as the staffing ratios we've set for each risk pool. As far as the predicted enrollees, in the first year, we predict having about 2,500 enrollees. This would double in the second year to 5,000 enrollees, and again, doubling in the third year to reach our total of 10,000 enrollees. For our high-risk patient group, we felt that a good ratio to use for them would be a ratio of 50 to every 1 FTE, and this is because we feel these patients would require the most care and attention. For the moderate group, we set the ratio at 175 to every 1 FTE, and then for our low-risk group, who would require the least amount of care, we set the ratio at 250 to every 1 FTE. The staffing that we would use that are shown and reflected in this model would be used to basically start to address the primary care needs of our patients in the beginning. And this would happen with first identifying patients, as we previously mentioned, through things like ER visits, database inquiries, or physicians knowing that some of their patients are dual eligible and encouraging them to enroll. After we've identified patients, we would provide them with any educational materials that they may need to understand our program and hopefully encourage them to begin enrollment. Once patients are enrolled in the program, we would have them complete an initial visit with primary care provider. And during this visit, our case manager associates would work closely with the providers in order to establish those individual care plans. Patients will be assigned to a team that will consist of having meetings as necessary for each patient, which would include providers, the patient, and when possible, their families. In the event that any patients would require any home visits, we would have our staffing go out and meet with patients outside of our facilities. In the event that any of our patients would come in through an ER visit or an hospital admission, we would have our nursing case managers work closely with providers in order to establish a discharge plan for each patient. And then following that, our case manager associates would follow up with the patient and ensure that they're able to adhere to the care plan that has been established. We feel that a key component of our model being successful is continuous communication. In order to accomplish this continuous communication, we felt that the full implementation of the EPIC system, as well as making it clear how important that follow-up communication is between providers and from provider to patient. And this will give us that result of continuous communication. We've established that our structure will meet the preventative care needs of patients in that in the beginning, when primary care physicians set those individual care plans, they would be sure to include any routine checkups and screenings that patients may need if they're at risk for certain diseases. Next, we will have our CMAs, again, following up on these care recommendations with patients to ensure that they're able to adhere to the plan. And then from there, the patient's health status is begun to be tracked through the EPIC system. So that if we notice any problems with any particular patients that may result in avoidable readmissions later down the line, we can try to prevent that. And then again, the follow-up communication between team members and from provider to patient is always key. In the event that we recognize any patients would have any possible behavioral health issues, we would have our licensed clinical social workers come in and have a clinical assessment performed on the patient. They would document this encounter and then work and collaborate with the provider in order to establish a care plan for the patient. Our model would address social support needs in the various ways. We would make use of our case manager associates, our nursing case managers, and our licensed clinical social workers, and that they would be knowledgeable on all resources that are out in the community available for patients to use. They would then communicate this information to patients based on each individual's needs. They would also work to coordinate the care and services for patients so that if a patient needed a referral or had any access issues, they would be able to resolve those issues for the patient. This map shows the coverage area that we have established through the use of our partners. The partners we've identified that we would choose to work with is the Neighborhood Health Alliance, the Family Service Counseling Center, and Lutheran Social Services. The combination of the services provided between our partners would ensure that we are able to meet the primary care needs, preventative care needs, and behavioral health issue needs of our patients. In order to ensure the success of our model, we felt that we needed to identify our key stakeholders that would be involved.
When identifying our key stakeholders, we decided to focus on individuals or groups of individuals who would contribute to or benefit from this care coordination model. The first group is the dual eligible enrollees, who is a target patient population of this care coordination model. They will serve as a source of information regarding the quality of service received, as well as ways to improve those services. They will also serve as a valuable source of information regarding their current health status. Our care teams, who will be responsible for ensuring that our patients receive quality care, will provide us with information regarding complications around coordinating the care among this patient population from a clinical standpoint of view. The identified health plans, both Aetna and Buckeye, will provide our patients with access to primary and preventative care services. Social service organizations will serve as a community-based source of care for this patient population. State agencies will work with the system during the development and implementation phase to ensure this care coordination is successful. And the community leaders, who we plan to connect with through groups such as advisory groups, will work with this system to ensure that the care coordination model is successful. Developing a relationship with these key stakeholders is very important to the success of this care coordination model, and to monitor the success, we decided to go with quality metrics that will focus on preventative care, effectiveness of care, patient satisfaction, access to care, and utilization. For preventative care, we have a list of the screening rates that we would like to see take place among this patient population, and associated with those screening rates, we have a quality metric objective of a goal of 80% in year 1, with the ultimate goal of 90% by year 3. To evaluate the effectiveness of care, we decided to focus on those quality metrics that focus on conditions that tend to result in high utilization within the hospital and the emergency room, such as cardiovascular conditions, musculoskeletal, respiratory, diabetes, behavioral health, and issues around medication management. Again, the individuals with the identified conditions, we would like to see those individuals receive the services within the spectrum of care at an 80% rate to go to ultimately 90% by year 3. As for patient satisfaction access to care, we decided to look at these elements of quality metrics because we felt that it would help us understand how the care meets the patient's needs and how well they're able to access their care. And again, we have a goal of 80%, and we would like to see that go to 90% or better by year 3. The concept behind improving preventative care provided the effectiveness of care, patient satisfaction, and access to care is that by doing so, we will be able to reduce our overall utilization and readmission rate over the course of 3 years. Being able to achieve these quality metrics is going to require a high level of patient engagement. Our patient engagement model is going to take a self-directed approach in which the patient and their family members will develop an individualized care plan in a patient-centered environment with the assistance of individuals within the health system. As you can see depicted in this model, the patient and their family would be the center of care, with the healthcare team and the community being built around their individualized needs. Respect, integrity, compassion, and commitment, teamwork, and innovation will be the guiding forces of the relationships that are built within this system. Our patient engagement model was based on this model developed by the McCall Institute, which is basically stating that with the healthcare delivery system in place and the community in place, in order for there to be improved outcomes, there has to be productive interactions between the care team and the patient. It is through these productive interactions that we believe providers will be able to better understand the needs and wants of the patients, as well as better educate them on how to self-manage their care outside of the hospital. To support our care coordination and patient engagement model, we have developed a strong financial platform.
Thank you. Okay, so our strong financial platform uses a value-based reimbursement structure that consists of 3 elements: our capitation arrangement, our shared risk arrangement, and our physician reward model. The capitation arrangement is going to consist of a capitated adjustment rate, or per member per month rate, for both Medicare and Medicaid. We're going to focus on our primary care, our specialty care, long-term care, our hospice, and also the coordination of the care. Depicted below in the table, We have described in our low risk, our moderate risk, and our high risk individuals are going to need different utilization of our resources. So we've used this risk adjustment for low risk individuals who are going to require $850 per member per month for Medicaid. For Medicare, or for Medicare. For our Medicaid, we're going to require $90 per month. This risk adjustment is going to go up for high-risk individuals for Medicare, $950 per member per month and $100 per member per month for our Medicaid. Our care coordination model anticipates to see a loss in year 1, a loss in year 2, and an operating income of just over $2.5 million in year 3. Key assumptions that we felt we needed to identify were our operating expenses. We anticipate that our operating expenses are going to be 85% of our revenue in year 1. Through the reduction of utilization and the elimination of fragmentation of care, we anticipate that our operating expenses are going to reduce significantly over a 3-year model to 82% in year 3 or in year 2 and 80% in year 3. We have kept our administrative expenses consistent across the 3-year model at 5% of our revenues. And additionally, we have physician consultants who are going to be focusing on care that we cannot provide within our system. And we anticipate along the lines of reducing our utilization and elimination of fragmentation of care that in year 1, they're going to be at 8% of our revenue and reduction to 7% and ultimately 6% at the end of year 3. Finally, our last key assumption is our enrollee phase-in process. We anticipate starting the enrollee process after month 2 of year 1. We're going to additionally phase in our enrollees up until month 5. We're going to do the same thing for year 2 and year 3, where we begin at month 1 and phase in our enrollees until we meet our numbers for 2,500 enrollees after year 1, 5,000 enrollees after year 2, and 10,000 enrollees after our 3rd year. The shared risk arrangement is going off the assumption that we are going to save 5% total after this 3-year model. 75% of our 5% savings are going to be reinvested into our model. This is going to consist of reimbursements going to our providers, our suppliers, the development of complex case management, our analytics, our health information technology, to include our Epic system. 25% of the total 5% saving is going into our physician reward model. We're going to be basing it off of quality outcomes, patient satisfaction, and the financial efficiency of the management of care. Below in the table, the shared risk arrangement, we see a loss in year 1, so there will be no savings. A loss in year 2, again, no savings. Within year 3, we will realize our 5% savings. And CHP and their partners will share a little over $6 million, and the physicians will share a little over $2 million in the reward model. The physician reward model is broken down into readmissions, quality metrics, utilization efficiency, and patient satisfaction on which they will get paid for. So we determined that 5% of readmissions, 5% of the 25% is going to be based on readmissions. 10% is going to be 10% of the 25% is going to be based on quality metrics. 5% of the 25% is going to be based on utilization efficiency, and then another 5% of the 25% is going to be based on patient satisfaction, equaling their share of the shared savings. As my team members and I have developed this care coordination model, we feel that it meets the needs of the patients. It will eliminate the fragmentation of care, reduces the overall utilization and cost of care, while improving the overall patient health outcomes of this dual-eligible population. And this concludes our presentation. So, questions?
Yes. One of the you identified a high, moderate, and low risk group. How did you identify the criteria to decide which group was high, moderate, and low for risk group, and who was identifying this in your care model?
Well, we base it off of the complex of their needs. So if they're just 65 and older and they seem to have a healthy lifestyle and they don't really tend to have as many chronic illnesses, we would consider them to be low risk. And then if they are 65 and older, or if they have like some complications but it's not major complications, they would probably be moderate because we consider that they would need as much care. But then those individuals who have multiple complex conditions, we would consider them to be potentially high risk. And if we notice that they have issues adhering to their care plan, we would also consider them to be high risk. And this would be assessed with the individualized care plan that we have attached in the back of the book that we gave you, and also by interactions with the case managers and the patient and the providers within the system.
There's one question to add to that. So on slide 16, you had several diseases that you identified for preventive care.
Yes.
Were these specific to this region, geographic region in Northwest Ohio, or was that basic demographic information that's nationally known?
Well, this is just, we decided to use these because we felt that this would be able to be used in this patient population by preventing these illnesses, like by being able to detect them earlier. And we do feel they do reflect the demographics. For example, breast cancer and glaucoma in older adults. These are older patients, so being able to screen for these, we feel would be very, I guess, appropriate for this patient population.
But you didn't identify what percentage of these patient population had these diseases, though, correct? Or did you?
No, we did not,
Okay.
but this is just saying that we would like to see this screening rate within this patient population if they have not been identified to have this condition.
On that point, were you able to look at the current benchmarks for each of those in terms of the screening rates, the current rates?
Well, no, we looked at some of the Medicare Advantage rates, and we kind of used that as a basis, but we made our own assumptions off what we thought would be most appropriate.
And so that's how you came up with the 80% as a target for all?
Yes.
Are you able to speak to patient recruitment into the program?
Yes, as far as patient recruitment, we would have community outreach workers trying to go out into the community and speak with people who may qualify for our program about it, as well as a little bit of marketing. Marketing would take place. And then, as we mentioned, patients a lot of times may come in through ER visits or being admitted into the hospital, and that's where they're going to have that initial contact with both the primary care provider and a nursing case manager who would sit and talk with the patient, identify their needs, and develop that care plan. So that's where we would try to pull them into the program.
So you would do recruitment during their ED visit and their inpatient stay?
When possible, yes. If those patients haven't already been previously identified through going out into the community or reviewing EMR records, then we would try to pull them in when they are identified when they come into the ER, because we would have triggers set off, like in the EMR system, to identify this patient as dual eligible.
To that end, I do notice that you have your marketing costs remaining constant over the 3 years at $6,000. Can you tell me what that includes and how that $6,000 will go to get upwards of 100,000 enrollees?
100?
Or 10,000
Okay.
enrollees?
I didn't.
I added a zero.
So we anticipated that these marketing costs were going to be incurred through just flyers that would be utilized within our system already, and then for some local marketing. Because we anticipate that we're going to already have some enrollees within our system, and that there's not a lot of marketing that will be needed to have this patient engagement enrolled in our care model, we felt that we didn't need to overextend our marketing budget to go over, above and beyond.
Do you think that 6,000 will get you enough flyers? If you're just doing the flyers?
Under my
Or just gonna
assumption,
stick with the printing costs?
I don't have a marketing background, so that was just an assumption that I had made.
Okay.
What are the incentives that your key stakeholders have in participating in the program?
Right. We feel that this is a direction that healthcare is going overall. It's value over volume. And so we feel that if our the providers that want to partner with us all have the same mindset and the same values driving behind wanting to have greater patient outcomes and patient satisfaction. And so although we see a loss in year 1 and year 2, we do feel that the hard work driven through year 1 and year 2 is going to not only reap benefits for our patients, but also reap benefits for our organizations involved.
So you'll share some of the savings with your stakeholders, like your
Correct.
social services?
Correct.
They'll get part of the savings.
Yes.
Do you see a need for technology other than the Epic implementation that's currently underway?
This is one of the key things that we identified, that Epic is not going to be the only technology system that is used in order to communicate between all of our partners. Health information technology is extremely important, and that consists of different or various systems that need to be able to talk to one another. So we have identified that there is a need for other systems, quality metric systems, and other electronic systems that are going to have to talk to one another in order to have this overall care model be coordinated and eliminate the fragmentation of care.
And that is included in your assumptions?
Yes.
We noted you're working with both Buckeye and Aetna. Could you share a little bit more about your rationale for that, and also as you get into the financial risk sharing, how would they be motivated to participate?
Well, we initially chose to go with both Aetna and Buckeye because we felt that it would not only increase the competition for the services provided, but it would also give our patients an option, which goes back to wanting to get the patient engaged in their care. So by allowing them to choose which plan they felt would best fit their needs, we felt that would be the best way to go, by giving them an option between Aetna and Buckeye. And I don't know if you want to speak.
Yeah, when entering into our care coordination model, there's obviously going to be legal binding contract based on the risk provided by each provider. So we don't have it broken down specifically for how much risk each provider is going to partake in, but the payment, the shared savings will be based on the amount of risk that each provider is going to incur, financially, mostly financially.
So I have a question about your revenue assumption. So on the page that has the capitation arrangement,
Yes.
and it says how much revenue you'll get for Medicare and Medicaid for each risk group. Where did that number come from? Was that given to you, or is that a number you derived?
So I had talked to individuals within the industry about Medicare Advantage and looking at various CCEs that are in the market. These are just benchmarks that we have come up with to use as a baseline.
Okay, thank you.
I have a quick question just on your staffing expenditures in your attachment D. I noticed that you have 0.75 FTE for the Director of Care Coordination. So I was just wondering why less than one full FTE for?
We feel that this director is going to have, they're not going to have to be using 40 hours a week in order to overwatch this care model. We felt that they may need to use 20 to 30 hours a week, depending on the complexity of the care model, but we felt that we didn't need to really fully engage administrator in coordinating the care. It's mostly going to be from the ground up, so our physicians and our clinicians are going to be doing most of the groundwork.
So I notice you also have physician consultants in your model. They're coordinating with their primary care physicians?
Correct.
And just for about 10 seconds, what's the specifics of their role?
So these are going to be consultants that the purpose of their role is if we don't have the specific patient needs or services within our care coordination model, we will be able to reach out to these physician consultants.
Thank you.
Thank you.
Thank you.